Hello, hello. Good to see you. Happy Tuesday. Glad that you're with us. I am very excited to have you with us today and with our speaker, Heather. If you were on yesterday, you get back-to-back Heather. So before we get started, my name is Anissa Mitchell. I'm with PMD Alliance. I'm really glad that you're all with us today. I want to invite you to open up your chat box, hover over at the bottom of your screen, find that little chat button, click it open, and give me a shout out. Let us know where you're joining us from. We love to see where all of our friends are hanging out at, joining us from, and helps us to feel connected to you. That is where you're going to be asking your questions today. We'll do that at the end. Heather has a full slide presentation that she's going to go through, and then we will go through some of your questions. We'll keep track of them, make sure that we can ask those important questions I know you have. So Heather is, so if you didn't join yesterday, she's a speech and language therapist. She's a consultant and expert clinician in training and certification faculty with LSVT Global. She works with LSVT Global. If any of you have done LSVT Loud or Big, that is the organization that she's affiliated with. She specializes in neurogenic voice and speech disorders, as well as diagnosing and treating dysphagia, dysphonia, and upper airway disorders. She's well presented nationally and internationally on LSVT Loud, Parkinson's disease, cough, and dysphagia. She has published many articles and even a book chapter on speech treatments for upper airway disorders, because I think we are in good hands with Heather today. So welcome, Heather.
Thank you so much for having me. It's truly been a highlight to be able to be with you 2 days in a row. It's been a fabulous start to my week, and I'm eager to talk to you today about something very different from yesterday's talk, which was about technology and research. And today we'll talk about swallowing issues in Parkinson's disease. So I'm going to do a screen share, and I have some slides that I'll be presenting on for you to watch as we go. And we'll have a question and answer portion at the end. And here is the magic share button. All right, does that look okay?
It does, it does.
Great. All right. So yes, thank you for the wonderful introduction. And I am going to be, whoops, let me get on the right. There we go. So thank you for the wonderful introduction. And this is more of that background into my bio. I am joining you today from Denver, Colorado. And in addition to my tenure with LSVT Global, I also worked for 13 years at an outpatient respiratory hospital in Denver, where a large portion, about 50% of my caseload, was on swallowing diagnostics, as well as treatment and collaboration within the medical team for those patients that had diagnosed swallowing issues, dysphagia. And so what we really want to start off with in terms of feeding and swallowing is how vital feeding and swallowing is for proper nutrition. It's very critical, of course, but also healthy swallowing, that mechanism that occurs, is important for protecting the airway. We don't want anything entering the airway except for air. And this is true when we are awake, when we are eating, drinking, also when we're just swallowing saliva, or if we have some, secretions that need to be moved down. And this occurs when we are wakeful and when we are sleeping. We know it's also eating and drinking. It's a very important aspect of our social interactions during daily living, whether it's conversations at the dinner table, meeting friends or family out for, a meal or a drink. And we communicate a lot during that time with our friends and family when we're having those meals. So we want to make sure that we all have safe feeding and swallowing for both basic bodily functions and the important social needs as well. So first, let's talk, what is swallowing? It's something that, we start doing before we're even born. We do it when we're in utero to start getting the mechanism coordinated and getting a workout. So it's something that is very easy to take for granted because we've literally been doing it our whole lives. But when we break it down, swallowing is very complex. It's a complex sequence of movements. It's also coordinated by very special neural circuitry in the brain. And these same neural circuits that are activated when we're swallowing are also activated when we are breathing and when we're chewing. And feeding and swallowing, even though it really is one continual movement from the mouth down the throat to the esophagus, we talk about it in stages. It's often when medical professionals talk about swallowing, it's broken down into a series of phases to just better understand what is happening during swallowing. So even though it's continuous movement and the phases overlap, I want to talk to you about the phases that are broken down. Not only is this important for just understanding what happens with swallowing, but also if you've ever been diagnosed with an eating or swallowing disorder or been told you had dysphagia, sometimes it's pronounced dysphagia. If you've ever heard any of those terms in regard to your care, we want to explain first the oral stage. This is the first phase of swallowing, and it's going to include, honestly, it actually starts before food even enters. We have sort of the preparation phase, the phase of getting food or liquid to the mouth for now the oral phase of biting, sipping, chewing. When we're doing this, we're not just taking a sip or chewing our food. We may not even realize that our chewing and the way our tongue moves and the way we sip, our tongue is also involved with that, so that we have the formation of a little glob. It's called a bolus, but for lack of a better term, for kind of the layperson, it's really just a glob. And this allows that formation of something cohesive to be swallowed down all at once. In the oral phase, we're also pushing that glob or that bolus to the back of the mouth with the tongue. The second phase is the pharyngeal phase, or I think of it as the throat phase. When food or liquid gets to the back of the throat, this is going to trigger a series of very rapid events that move the food or liquid through the throat to the esophagus and ultimately down to the stomach. These actions are controlled by the central pattern generators that I mentioned earlier, those neural networks. And what occurs here is not necessarily voluntary. It's kind of more reflexive. And so the airway is protected and closed at two different levels at the vocal cords, as well as the little flapper called the epiglottis. It's two layers of protection for the airway. And that closure is coordinated. That's why you may notice in the middle of your swallow, your breath is held. We shouldn't be able to breathe in the middle of a swallow. And so that's that pause in breathing to help protect the airway while the muscles in the throat push the food and liquid into the esophagus, which is actually a little lower in the throat than one might expect. The third phase is the esophagus phase, and this is where the top of your esophagus opens. Many people don't actually realize that when we are not swallowing, the esophagus is closed. It's a sphincter muscle. And so it takes the triggering of the swallow, the trigger of the reflexive components as food and liquid goes down the throat to ideally open the top of the esophagus, let the food and liquid in. And then the esophagus continues down and it will use a squeezing motion and gravity to move your food and liquid down into the stomach. Difficulty with any phase of swallowing, whether it's the esophagus, the throat, the mouth, or maybe a combination of all of them, this is diagnosed as dysphagia, or as I mentioned, some practitioners will pronounce it dysphagia. So what is a safe swallow? What does that mean? Safe swallowing is when your food or drink stays in the mouth after you've placed it there, that it goes through the throat without leaving any food or liquid behind. An example of this is if you've ever swallowed and felt like, oh, there's still stuff in my throat. I have to swallow a few times to get it all the way down. That's what we mean by saying the food and liquid goes through the throat without leaving any leftovers behind in your mouth or throat. It is a safe swallow if no food or liquid or the debris enters into the airway and that it moves through the esophagus without getting caught up. Without any delay, it easily transports to the stomach. Now, dysphagia includes not always all of these elements, but it can be one or a variety, a combination of these factors. Dysphagia can include incomplete chewing. So when we don't chew up our food nicely or it's not made into that nice glob that's easy to swallow, there's pieces left behind. It can also include food or liquid escaping the mouth. If we don't have a good seal from our lips, sometimes we might get liquid coming out or food coming out of the mouth. If food or liquid does get stuck in the throat or if it enters the airway, that is dysphagia that can lead to very serious complications such as aspiration or aspiration pneumonia. And dysphagia can also include in the esophagus phase, food or liquid getting stuck along the way. And I'll talk in more details about these specifics and how it relates to Parkinson's disease and treatment. Some fun facts about swallowing. The act of swallowing is also called deglutition, and the act of chewing is called mastication. It takes as little as 2 seconds and as many as 9 seconds for something swallowed to go from the back of your mouth down to the esophagus. So it is really fast. A lot of very complicated things are happening in a very short amount of time. And this involves more than 30 different nerves and muscles at work when you are swallowing. The Adam's apple moves up and out when we swallow, and that helps that little flapper that's in our throat that closes our airway, the epiglottis, to close. And so that Adam's apple may also be called your larynx. And so this is your larynx moving. And yes, men and women both have Adam's apples, but women's are much smaller. If you swallow and you feel your throat, you could actually feel the Adam's apple go up and down when you swallow. When somebody says something went down the wrong way, that's actually accurate. That's absolutely a true, accurate statement for medically what's happening when something enters the airway. And so saying something went down the wrong way, that feeling occurs when food, liquid, or even your own saliva goes the route of the airway instead of the esophagus. And it happens to all of us sometimes, and we end up coughing, choking to try to expel that food, liquid, or saliva. But when it happens frequently, Or even more significant, if it's happening without somebody coughing in response, that's when it can be truly problematic and worth getting hooked into being diagnosed and having a treatment focus developed for you. Another fun fact is that gravity helps us swallow, but it's not necessary. The strong squeezes of the throat and the esophagus as it moves food and liquid down means that they're so strong, and this means that we can actually swallow when we're upside down. So kind of a fun fact. And so with these facts in mind, I'm going to give you a little more information about how swallowing is examined. How do we know? How does your medical team assess this to see if everything is going well during swallowing? So this is under the treatment purview, the practice purview of a speech language pathologist, and other professionals will use clinical tests and instruments to see what's going on with swallowing. Now, from the outside, all of these muscles, these structures, where the food and liquid is going, it's not visible from the outside. So sometimes we need to use instruments to see what's happening inside the mouth, the throat, and the esophagus during a swallow. One example of such an instrument is a radiology exam. It's called a video fluoroscopic exam, and it takes place in radiology. It's often run by the speech language pathologist as the radiologist, or a technologist is running the actual equipment. And it is so cool. It is a real-time, like movie x-ray of you swallowing as you eat and drink. So it is occurring in real time, and that allows you to be assessed on the spot. It also allows the speech pathologist to see if there are simple compensations that can be used to keep an unsafe swallow safer, to keep things moving the way that they're supposed to be moving. So it's a very dynamic test. It's also very personalized, because what may be going wrong for somebody's swallow might not be what's happening in the next person's case. Even people with the same diagnosis, such as Parkinson's disease, may have very different findings on their exams. And so the speech pathologist is there with the radiologist to determine what phase of the swallow is affected, what can be done to intervene immediately to keep a swallow safe, functional, and easy, and to help develop a treatment plan. Because the really good news about swallowing is that it is addressable. It's something that can be addressed with personal treatment plans and exercise. And so what I'd like to show you now is an example of this exam. You'll see somebody swallowing a bite of a banana. And this person has a normal swallow, nothing is going down wrong, the muscles are working as they should. So I'm going to play it once and explain to you what you're seeing, and then I'll play it again because swallowing is so fast, so you have a second chance to view what is at action here. So the banana is going to show up dark on the screen. You'll see the person is facing forward, so you're going to see them from the side. You'll be able to see their mouth and their oral cavity as they're chewing the banana, and then you'll see the banana slide down the throat. When the banana is going down the right way, the esophagus and the squeezing muscles of the throat send the banana to the back of the throat. The front of the throat is where the airway exists. So we never want to see food or liquid going that way. So here's that bite. Chewing, making it into a nice glob. Now you see the dark banana coming down into the esophagus. There was a little left. They felt it and they swallowed a second time to get the rest of the banana down. So I'll play that again. I just have to go backwards. All right, with my mouse. All right, there's that bite, chew, nice glob, down to the back of the mouth, down the throat, into the esophagus, little leftover, second swallow, everything went the right way. So that's a great example of a safe swallow. Now, sometimes because of injury or disease, things don't go as planned. With Parkinson's disease, the prevalence of dysphagia amongst the PD population is 80% of patients. So as we begin discussion of the relationships and impacts of Parkinson's disease on swallowing, it's also important for me to point out that there is a lack of a relationship between the disease severity of the Parkinson's disease and how significant someone's swallow is being impacted. In other words, we may see people who have mild Parkinson's disease severity, but their swallow is very impacted. Perhaps they're silently aspirating food and liquid into the throat. And so there is a frequent lack of awareness of symptoms of dysphagia by patients, and that's due to some of the sensory changes that can occur with Parkinson's disease. So intervening early is certainly called for here, it's appropriate, and for reassessments to occur occasionally to ensure that the swallow is intact and safe throughout the diagnosis of Parkinson's disease being early or whether it occurred years previously. When we consider the processes of Parkinson's disease on muscle rigidity, we also know that there can be some muscle weakness that occurs. The hypokinesia, this means smaller movement. So not only is there smaller movement in writing or in how people with Parkinson's take steps, for example, but we also see smaller movement in how the lips, tongue, throat muscles, we see that smaller movement and that impacts swallowing. There's also the slowed movement. So the bradykinesia, the slower movement while we swallow. And as with any activity, you can imagine that smaller movement, slower movement during eating and drinking can absolutely impact us and can be a reason why we see an increase in prevalence in swallow issues with those diagnosed with Parkinson's. So all of these factors can affect each of the phases of swallowing in people diagnosed with Parkinson's. And some further detail on these points. So bradykinesia, the slower movement, matters for timing. As I mentioned, swallowing is fast. It's 2 to 9 seconds for something to go from the back of the mouth down to the stomach. So you can bet timing matters to close the airway on time and protect the airway. Timing matters in keeping food and liquid in our mouth, as well as in the coordination of all these structures in one continual motion. And the 3 phases of swallowing, we need that coordination there. So timing can make an impact. And the esophagus opening. The esophagus opening a little bit too late can result in food or liquid pooling up in the throat and not easily entering the esophagus. It can get kind of hung up there. So that matters too. The smaller movement, that changes our range of motion. And when it comes to eating and drinking, range of motion matters for how well we're chewing our food, how well we're creating that little glob, that bolus to form into one nice, manageable item to swallow. Range of motion, smaller movement matters for keeping the Adam's apple, that ability for it to move up and close that little flapper, that epiglottis on the inside so that the airway's closed. And the range of motion matters for the swallowing to squeeze those squeezing muscles in the throat to get food and liquid down into the esophagus. But with all of this knowledge of how Parkinson's disease can affect swallowing, there's really good news. And that is that exercise is medicine, and that exercising the oral, throat, those muscles of swallowing and eating and drinking absolutely is shown to have positive impact, to not only just maintain function, but actually improve function and safety of the swallowing mechanism. And early intervention certainly helps with that. The sooner we can start exercise, the better. We also want to acknowledge that there are some non-motor impacts on swallowing in Parkinson's disease. This can affect the sensory deficit that may occur that I talked about briefly before, but for more detail on that, sometimes when people with Parkinson's are swallowing, they don't always feel, oh, I have saliva in my throat that's left over, or I have a little food left in my cheeks. I need to swallow again, like the man who ate the banana felt something left over and he swallowed a second time just reflexively. Sometimes that's diminished in Parkinson's disease, as well as the sensation of food or liquid entering the airway in people before diagnosis of Parkinson's disease, before they have symptoms. Something going into the airway elicits that strong cough, that something went down the wrong way, and they might say they're choking, but they cough whatever it is out. With a sensory deficit, something may enter into the airway, what we say silently. So you may have heard the term silent aspiration. We also know that reflux, so whether it's GERD, whether it's reflux that comes into the throat, can have an impact. Slowed digestion, gastroparesis. And then, of course, when swallowing and eating become effortful and now takes energy, we can see that meal times can be a little less motivating. Maybe we're not feeling as social when we're meeting with people or having dinner at the, family dining room. Dehydration may occur if people are subconsciously not motivated to be eating and drinking the way that they used to be. So dysphagia in Parkinson's disease has big repercussions and a multifactorial basis. So I got a little bit ahead of myself, but here is a slide on more of that to which I spoke to on the sensory impact of swallowing on Parkinson's disease. So the small, slow movements, the bradykinesia and the hypokinesia, might be perpetuated by that abnormal sensory feedback. So that sensation, or that phenomenon rather, that we're not feeling food or liquid sticking behind. We're not always feeling it entering the airway. This can result in reduced awareness of the swallowing difficulty, the lack of the self-correction, such as swallowing twice for something sticky like a banana. And it may be that folks are able to respond positively to an external cue, like me working with a patient and saying, hey, go ahead and swallow one more time for me and clear anything left in your mouth. And they can do that. They don't always feel it. They don't always sense it on their own. So they don't always spontaneously maintain or adapt treatment techniques. But we see that through intensive treatment with a sensory focus, that this can be improved, and that people start initiating and self-correcting swallows that perhaps left food or liquid behind or that went down the wrong way. And so the good news in terms of the sensory component of how Parkinson's disease affects swallowing is that treatment interventions can address and improve those sensory deficits. One of the things we've noticed with LSVT loud that was very unexpected was that voice treatment, such as the intensive, very sensory focused, very much focused on bigger movement, we see that voice and swallowing can influence one another. And so what we were noticing is patients, as they went through LSVT loud, were noticing improvement, less coughing during meal times, less wet voice for another symptom that was improved upon. And so we see through some research and kind of digging deeper into this and how other voice treatments perhaps had an impact on other people's swallowing as well. When we really looked at it, it made sense because feeding and swallowing and voice and speech share all of these same anatomical structures. We also know that breathing is very important for voice and speech, and also breathing coordinated with the appropriate breath hold during the swallow is also something that the two behaviors have in common. They both require coordinated activity across breathing, throat, and the oral cavity systems. And we also know that a voice disorder in Parkinson's and a swallowing disorder in Parkinson's have the same underlying pathology, and that's the muscle rigidity, the bradykinesia. Both of those appear to underlie voluntary speech, as well as the volitional, the voluntary portion of the oral stage of swallowing. And so these problems in movement scaling being smaller and those sensory challenges are both integrated and characterize both speech and swallowing impairments associated with Parkinson's disease. Another possibility of why swallowing and speech might be commonly impacted by Parkinson's disease is that there appears to be at least some degree of shared neural circuitry between the two behaviors. And we know that Parkinson's disease results in some degeneration of these neural systems and networks. A variety of behavioral treatments have been used to improve Parkinson-related swallowing deficits, but very few have looked at voice and speech treatment on swallowing. And so, as I mentioned a few decades ago, maybe 15 years, maybe 20 years, looking at patients who were undergoing LSVT loud and reporting these improvements in Parkinson's disease, we saw some interesting analysis when we really looked into it. Now, for those of you who have or have not had LSVT loud, some of the key components of that therapy is that it incorporates principles of neuroplasticity. So it's intensive, it attacks sensory, it's meaningful therapy that are based on the client's goals. And it's administered in an intensive manner so that we're really challenging the impaired system. The target during that therapy is bigger movement, and this is done through addressing vocal loudness, taking a soft, very hypoadducted, very breathy, perhaps, voice, and bringing it up to normal loudness, where people are talking with normal intensity, normal amplitude of movement. And so the target of loudness addresses the smaller movement, the slowed movement, and the rigidity. The mode is intensive and high effort. It's 1 hour daily sessions, 4 days a week for 4 weeks. Patients also do homework and carryover exercises. And this is because exercise is medicine. We know that through our study of delivering voice therapy intensively in this manner, led to efficacious results. It led to results that made a long-lasting difference and improved voice and speech in Parkinson's disease. Whereas speech therapy that was an hour long, once a week, no homework given, didn't have those same impacts. There really was no change. LSVT loud also addresses sensory. Just like we want to address sensory in swallowing, we also have to address it in speech. And that's because people who have Parkinson's disease tend to talk quieter, but this feels normal to them. In their ear, talking like this and a normal loudness with good voice quality in their ear feels like they're shouting. And so there's this mismatch of sensory that also has to be addressed. And we know that sensory is best addressed through intensive therapy. So the intensity occurs across the sessions. As mentioned, it is 4 days a week for 4 weeks, 1 hour individual treatment, homework and carryover, and that this is exercise people continue to do on their own for daily, 15 minutes a day. They're keeping up that voice exercise. And within the sessions, it's also high effort that we are addressing amplitude, multiple repetitions. We're getting people a really good workout in that therapy. And when we looked at the evidence, what happens? We see here from this graphic that multiple parts of the body were researched and found to be positively impacted after LSVT loud. And the one that I have highlighted in the box there are a couple of studies that looked at swallowing and how those improvements occurred after therapy. This slide is a great summary to keep in the back of your mind to think about why would a voice treatment have an impact on swallowing? Well, during voice treatment, the vocal cords are coming together. And we know in swallowing, when we swallow, the vocal cords, in addition to the flap, also close the airway. This voice treatment addresses monotone voice that may occur with Parkinson's disease, and there's pitch exercises. We also know that the larynx, the Adam's apple, raises not only for pitch, but it also raises when we swallow. So there's that workout on that range of motion. And we also see between voice treatment and swallowing treatment that they are both very coordinated behaviors that we do. Both involve breathing, they involve the vocal cords, they involve the tongue, the lips, the palate. And so by exercising those muscles intensively in voice, there may also be this positive impact on swallowing. And so there were first some anecdotal reports that really drove this research. And the first study that I have referenced here, if anyone would want to look it up after the presentation. But to summarize the main findings, it was found that after LSVT loud, there were improvements seen in tongue function and how well the tongue was moving food and liquid from the front to the back of the mouth, the tongue strength, and how well the tongue could keep that nice little glob, that bolus, stabilized so that we weren't having leftover or spillage out the front of the mouth. And that swallowing was just more efficient, which means that it takes less energy to eat and drink. Eating and drinking should not be effortful. And so when it starts to get effortful, swallowing is less efficient. And we don't want to burn calories. We want to bring on calories when we're eating and drinking. The next study from Miles et al. Looked at patients, there were 8 of them, who filled out questionnaires about their eating, drinking, and swallowing. And it was observed that after therapy, 6 of those 8 improved on their noted self-reportive symptoms. 1 person remained the same, and 1 person did have a worse score. And when they had their swallow study, their X-ray video fluoroscopic exam, like the video you saw earlier, they did see better improvement in the esophagus opening, the way that it should be in a timely manner and a complete manner, and that there was less residue within the mouth and the throat after swallowing like a sticky substance. They also saw improvements in cough. We know sometimes things do go down the wrong way, but if we don't have a strong cough to get that out, then it may be a cough that's not efficient and is still letting food or liquid stay in the throat. So we were actually encouraged to see improvement in cough expiratory flow rate, so the strength of the cough. It is very important, though, for me to point out that all of these findings were quite interesting and exciting to think we might be getting some benefit to the swallow and the voice. But I would not say at this point that LSVT loud is a replacement for direct swallowing therapy. It is not a replacement at this time. And we really need that focused swallowing intervention on people who have a known dysphagia. So, summary of those cross-system influences. So the influences, the positive things that happen for voice and for swallowing. The positive influence of speech, perhaps speech treatment, driving and changing at the neural level and brain protection that we saw during PET scan research that we did. We also saw speech and swallowing sharing some of the same brain network. So perhaps that's another positive influence that one treatment can have on both systems. And that working on speech may positively impact swallowing. We know that speech and swallowing share anatomy, and that working on speech and voice anatomy exercises also works out the swallowing anatomy, which is pretty cool. And the airway protection, tongue control, the sensory influences of intensive treatment also have that positive impact. And as noted prior, it's very important to again note, LSVT loud does not replace swallowing therapy. The research is ongoing. We still recommend objective assessment and personalized recommendations. Those are the gold standard for anyone with questions about their swallowing function or symptoms or diagnosis of a swallowing disorder. So how do we know if there are some impacts to your swallowing or to your loved one's swallowing? And what do we do about it? If you observe in yourself or if you observe in those that you know, signs or symptoms of swallowing disorder, such as coughing when eating and drinking, a wet voice quality after eating and drinking, food or liquid coming out of the mouth, or if there are unexplained pulmonary infections that aren't related to something else medically going on, it's an unknown cause. Or just chest congestion. Those infections or the chest congestion can be signs that food or liquid has made it into the airway. So the next step is to obtain a physician order for a swallowing evaluation. And that modified barium swallow study or the video fluoroscopy, it's the same terms for the same exam. That is the gold standard exam for finding the specific challenges, which muscles are being impacted, the specific impairments. It also finds, which is the really great news, appropriate, actionable, feasible, compensatory strategies for someone to immediately start instituting at the time of that exam. So it's a very proactive exam where you get the results right away. It will also help patients determine the safest diet and personalized long-term recommendations, including exercise programs, follow-up treatment with the speech pathologist on those exercises, or perhaps strengthening respiratory responses like cough. We know not all swallows are the same, and the recommendations are tailored. Now, some patients will say, well, my voice is quiet. It's hard for people to understand me. I want to have voice treatment, such as LSVT loud, but I also have signs or symptoms or a diagnosis of swallowing disorder, of dysphagia. So what do? We tell clinicians and we tell our patients, you need to prioritize the treatment focus if there's voice and swallowing deficits occurring at the same time. It may look different for each patient. So the therapist, the speech language pathologist, and the medical team will help determine the treatment focus to do. If the dysphagia signs or symptoms are mild or non-existent, if there are no history and no signs of chest infections or bronchopulmonary infections, and if the physician approves that it's appropriate, LSVT loud may be the first to prioritize the voice treatment first. If there is, though, a dysphagia diagnosis, we want to get that treatment underway. And this is where you would do that diagnostic workup and the treatment first. So if there are significant, so more moderate or severe dysphagia signs and symptoms, if there's a history of pneumonia, bronchopulmonary infections, a lot of chest congestion, particularly if they are ongoing, definitely we want to address dysphagia first. And if a person has been placed on any dietary limitations, so if they are only allowed thickened liquids or a pureed or mechanical soft diet, we would say address the eating and drinking, address the dysphagia first in that scenario as well, because the ultimate goal is to get people back on a full diet where they're able to eat and drink a variety of consistencies as they did previously. And then some patients may do both treatments at the same time. They might want to tackle both of them at once. So this is what we call concurrent treatment. We say that to the clinician, they still need to adhere to the LSVT loud protocol when providing the voice part of the intervention. And that's those 60-minute sessions, 4 days a week for 4 weeks. But perhaps within that same visit to the clinic, after or before they do their LSVT loud session, they may have their speech therapy for dysphagia and exercising the swallowing muscles. Some people will do this back to back and just knock it out. Other people, though, might need a break. It might be too much energy for them to do 2 therapies back to back. So perhaps they have a little break in between. This will depend on the facility and insurance. So it's something, where multiple considerations occur. But for some folks, it's appealing to them to do the concurrent therapies. Why have swallowing therapy at all? Why have swallowing therapy with a speech language pathologist? Well, the reasons are because you can improve. We know that exercise is medicine, and that's true for all of the swallowing muscles in the mouth and the throat. Absolutely, we can work those out. We also want to keep people safe. We do not want aspiration pneumonia to reoccur if it's already occurred. And ideally, we want to prevent it from happening at all. Aspiration pneumonia leads to hospitalization, can lead to long-term breathing impacts, and it can also be deadly. So we want to keep the swallowing safe. And as I mentioned at the top of the presentation, we want to maintain the joy of eating and drinking because it is a social component. It's something that we want people to stay involved in and to enjoy. So when seeing a swallowing therapist, which would be administered by a speech language pathologist, we say early intervention certainly helps, but People across the severity levels of their Parkinson disease or their swallowing impact can benefit, but early intervention is always helpful when we talk about exercise. And when seeing a speech language pathologist, they will give specific exercises, specific repetitions of those exercises to strengthen the swallow, to improve the coordination of what's happening in that very fast sequence of events. And also some patients need exercises to improve the coordinated breathing for the swallowing sequence. This may also include breathing muscle strength training, getting the breathing muscles stronger and getting that more efficient cough. So if something slips down the wrong way, we're able to eject it when we cough. The speech language pathologist will also take into account dietary considerations, such as calorie intake to maximize energy so that eating and drinking isn't tiring somebody out. Viscosity, how fast something moves. Water moves very quickly, but a bite of banana moves much slower. And so sometimes that timing matters because of bradykinesia. We talked about the sensory element also mattering. And so some speech language pathologists will work on the sensory component through initially starting therapy with something that's very cold that people eat or drink, or something very sour, kind of waking up the sensory system. It's very person to person. And for those who are on a thickened liquid diet, they may be a candidate for what we call free water. And this is getting together with the medical team. The physician's approval is required to see if someone can drink plain, unthickened water to increase their hydration. But that is only done at times when the person is not eating or drinking, so that we don't have any food potentially going down with the water. And it also requires good oral hygiene. So the specifics of that would be discussed with the speech language pathologist. That therapy, one of my favorite to do in the hospital, because it was getting people back on track, getting that joy from eating and drinking, personalizing, finding how to tailor it for each person was really fun. Seeing the empowerment and getting people motivated to eat and drink the things they want again. I must also give kudos to an interdisciplinary approach. Working with an occupational therapist may be appropriate too. They help with some of the fine motor. So think of getting the food from the plate to the mouth, or the drink from the cup into the mouth. They have assistive devices. They also may do therapy focusing in on movement that may include LSVT big. Some general tips for swallowing. And again, I want to just say general. These tips are general. They're not a blanket statement, because it's not one size fits all when it comes to swallowing. But these can be some good general tips as you're awaiting diagnosis or treatment, particularly if you have more of a mild case. And these are honestly good tips for most of us. So limiting distractions, like not having the TV on, not having a lot of movement as you're eating and drinking, thoroughly chewing, swallowing one bite before you take the next. For those of us that want to kind of shovel our food in, really make sure you've completely swallowed one bite before you take the next. Taking one drink at a time versus a chug, 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 chug tends to be safer. Having your head straight and neutral position, meaning not craning back like this to drink, can be very helpful for positioning that little flap in the throat into a position it's easier for it to close. I mentioned very cold or very flavorful may help some folks increase their sensory input. Swallowing twice, like we saw with the person with the banana, we often need to swallow twice to get something down the whole way, especially if it's a big bite, but not a bad practice to get into each bite, each sip, swallow twice to make sure it went down, so that if your sensory system is impaired, you're not chancing something being caught that you're not feeling. staying well hydrated. Muscles and certainly the throat work better when we are well hydrated, and that is certainly true for swallowing. And just monitoring, perhaps asking someone. We don't always realize when it's occurring to us, but sometimes those that we're dining with, we may ask, hey, can you let me know if I cough or clear my throat a lot during meal times? That could be a sign something's not going down right. That can be a nice tip to do. So I know we just have a few minutes for questions, but just in summary, the etiology, the reasons for swallowing being impaired in Parkinson's disease is multifaceted. It's complex, which is why therapy is so important to be tailored because it is complex. We know that slow movement and smaller movement are the drivers in disordered swallowing for those with Parkinson's disease. There is a common underlying physiology that impacts voice and swallowing for those with PD. And there's some initial research suggesting that addressing voice in an intensive exercise and sensory focused manner may have a positive impact on swallowing, but that truly the individualized diagnostics and treatment remains the gold standard, and LSVT loud does not replace dysphagia treatment. But it is kind of that nice bonus of thinking, oh, I might be helping two things at once when I do my loud therapy. Prioritizing treatment patient to patient as indicated and able, and that we may benefit from folks in occupational therapy who can help us with the feeding component that gets the food and liquid to the mouth. So with that, I'm going to close the, I'll leave this up for a moment and then we'll open it to questions. I wanted to put this up here because if questions come up after this presentation that you may have, you can email info@lsvtglobal.com and those questions will come to myself. We can help to answer any specific questions that you think of later. And then for today, were there questions that I can help answer?
Yeah, so we actually had quite a few, and unfortunately, we're not going to be able to get through all of them, but I'll try to highlight a couple of them that I think a lot of people should know about. And we talked about it a little bit earlier, like the silent aspiration, and then just food getting into the lungs versus into the stomach. So this question is surrounding aspiration pneumonia. So this person's husband just got out of the hospital diagnosed with pneumonia. The ER nurse thought that he might have swallowed water during his medication. So taking the water and the meds down and going into the lungs. So they wanted to know if that's possible. And I know that it is, and I know that that's a big issue and one of the big reasons people end up in the hospital. So can you touch on that a little bit more?
Absolutely. And it's a very vital question because anything entering the airway other than air has the potential to bring bacteria with it. And so that's where I mentioned like free water, if that is ever appropriate and deemed necessary by the medical team, we want to ensure good oral hygiene. When we think of our mouths are not clean. They're not the cleanest place. And so we want to ensure, good hygiene with brushing, not only teeth, but in between the teeth and the cheeks and the mouth. And also water is the fastest moving thing that we swallow. It has the fastest viscosity. And so the idea of timing mattering. Now you pair fast moving water with a very slow moving pill, and that can absolutely cause a discoordinated swallow to occur. And if you pair that with someone who doesn't have an appropriate cough response to get all that water out right away, it does make sense that they're thinking that may have caused the aspiration pneumonia. There's so many tricky parts to swallowing that really has to be coordinated. And so swallowing pills is something specific that a speech pathologist can help with and give suggestions, such as taking pills, maybe with a bite of applesauce, something that's going to stick with the pill. It's a little slower moving and more likely to go down the right way than something like water.
Fantastic. Oh, we have so many good questions.
I'm so sorry. I went too long.
No, well, and I guess somebody asked, and I think that it's important, they may not all understand what LSVT loud is. So that was one question. So I'm going to combine a couple of questions here so you can economy of answer. What is LSVT loud? Someone wanted to know if they can't get to a speech therapist 4 times a week, is there a way to still do it? And does singing help improve swallowing? So I'm going to combine those 3 questions into one.
Great. That's great. And I can give a nice answer, I think, to address all of them. So there's no evidence yet about singing being beneficial for swallowing, but we do know that it exercises all those muscles, it exercises breathing, it moves our Adam's apple when we go up in pitch. So there is that cross system of effects, just like there is with intensive loud, LSVT loud therapy. So it does, stand to be reasonable. But just like with LSVT loud, it's nothing that we would say would replace swallowing treatment, direct swallowing treatment. It might be that idea of an added bonus, which is great to have added bonuses in life, but would not be a recommended replacement. And LSVT loud is an intensive voice treatment that addresses not just the small movement, the slow movement of voice and speech, but also the sensory component. For those of you who ever feel like you're talking loud enough, but people keep asking you to repeat yourself and you think, everyone needs a hearing aid, that's an example of how pervasive the sensory component is. So the treatment not only is a great workout for the muscles, but it also addresses the sensory component and has been shown to have an impact with PET scan data, activating more of our speech neural systems after just 4 weeks. And to the point of it being difficult to get to a therapist 4 days a week, this is a therapy that can be done online. We have many trained and certified therapists who also specialize in telehealth and doing practice over the computer so that it's not so cumbersome to get to a clinic. If anyone has difficulty finding a therapist in your state who provides that type of over the computer treatment, or if you want a clinic close to you but don't know where to look, our staff is awesome at finding people. We keep a big database of folks and where they're located. So the website or info@lsvtglobal.com to email so that we can find you those resources.
All right, awesome. Thank you so much. This has been such a thorough, excellent presentation. I really appreciate your expertise. I apologize that we didn't get to go through all of the questions. Maybe I can squeeze some more information from Heather in a different way later to answer some of these questions. The recording will be up so that if you want to go back and review, because there was so much information packed in there, little nuggets of truth that you probably didn't realize that might impact you or your loved one, that hearing it a second time might help you. So feel free to utilize that resource. Heather, thank you so much for your time, for being with us for 2 days back to back. It's been wonderful. I thank all of you that's joined us today for this program. And if you would just give this wave of gratitude to Heather for her expertise, thank her for her time. We thank you, Heather. I thank all of you for joining us again, for getting out there and being a part of this and helping educate yourself. Thank you, everyone.
Thanks, everybody. It's been a real pleasure to spend this week with you guys. And yes, absolutely. Anissa, let me know what I can do to help with the questions that came in.
Awesome. Thank you. Everyone have a great rest of your day.
Thanks, guys.
Bye-bye.